Welcome to Evidence to Excellence, news in neuroplasticity and rehab powered by the Recovery Project. We want to personally welcome and thank you for joining us today. We're glad that you're here because this podcast is designed to keep you updated on what's new in research and evidence in the neurorehabilitation world. Now, here's your host, Polly Swingle, CEO and co-owner of the Recovery Project.
Welcome to Evidence to Excellence. Today, we're going to talk to a speech pathologist, Andrea Bettis. And I thought, what a time to really bring in such an important part of the rehab team, a speech pathologist. And Andrea and I were talking before we started today about so many people out there do not have the full understanding of what a speech pathologist does. I mean, a lot of the times, even when I'm talking to patients and maybe as a physical therapist, I'll recommend, I think you need speech. They'll be like, well, what's wrong with the way I talk? Or why do I need to talk any clearer? Or some people will even say, so they just work on the ability to public speak. And I'm like, yeah, no, that is not the case. So we're going to dive a little bit deeper into the scope of a speech pathologist and really some evidence, some science behind what you do. So let me give a little background. So Andrea Bettis graduated from Indiana University in a degree in speech and hearing science. She received her master's in speech language pathology from Eastern Michigan University. She is a neurospecialist. She became interested in the specialty of neuro following an internship at Specialty Rehab Services. Later, since she was hired there and worked there, she did become certified as a brain injury specialist. She wanted to expand her knowledge, her experience, her education, and in 2018, she started working here at the Recovery Project. Right now, she is one of our lead speech pathologists. She is certified in LSVT Loud and Speak Out, which we're going to talk a little bit about that today. She is also certified in Vital Stim, which I know that a lot of people I talk to have questions about what that is and what it's used for. So we're going to talk about that as well. So let's go ahead and get started. So I think first, and I kind of talked about this, people really don't have the understanding of exactly what you do and how beneficial your services are. So let's start with defining maybe the scope of a speech and language pathologist.
Okay. So the speech language pathologist scope of practice is really broad, and it actually kind of depends on what setting you're seeing a speech therapist in. So for example, a speech therapist who works in a school setting is going to have a level of expertise that I do not have because my focus has been on neuro. So in a setting like the Recovery Project, which is an outpatient rehab for neurological disorders, I work with things like voice disorders, motor speech disorders, things like dysarthria, so slurred speech, articulation issues. I also work with fluency disorders, so people who have a stutter or difficulty with their breath support for speech. But then I also work with cognitive difficulties, so maybe memory difficulties, issues with attention, executive functioning, which are those skills that we need in order to function on a day-to-day basis. And then the one thing that really throws people off is we also work with swallowing disorders. So I tell people we really work on like the neck up to just kind of narrow it down.
Very good. Yeah, I agree with you. I think I get that sometimes. They're like, well, swallowing disorders, I didn't know that somebody could even help me with that. Let's talk a little bit about the communication. And I know that from my experience, when I started out working, I worked a lot with people that had stroke or brain injury. And so what I would see as a physical therapist is some of them had difficulty in really speaking. They couldn't retrieve that word. They were very aphasic. But then I had people that could speak no problem. You can understand them, but they had a very difficult time understanding what you said to them. On top of that, they would have cognitive deficits. Mm-hmm. Sometimes it was judgment, that they really didn't have the best judgment anymore. Sometimes it was impulsiveness that affected their cognition and ability to really function independently again, meaning we always look at, are they safe? Mm-hmm. being able to live on their own and make those decisions that you have to make depending on what age you are at. So we, in this podcast, always talk about the science behind what we do. So I want you to give me, and I know there's probably a million different pieces of evidence that we can talk about, so I'm going to ask you to pick some and maybe give an example of something you do to work on some of the speech deficits within your scope, and maybe some science behind that, or techniques or approaches that you use that has that evidence behind it that we know that it is effective.
Okay, so like she said, it varies depending on the diagnosis. So I'll pick, like for example, our Parkinson's patients have a whole lot of good research behind the voice and speech and swallowing rehabilitation program for that population. So there's something called LSVT Loud, which is the Lee Silverman voice treatment that's been around since the 80s, and it emphasizes, neuroplasticity as far as lots of repetition of the voice exercises over a 16-week program, resulting in better speech and voice. So that's one technique or exercise program that is really evidence-based for Parkinson's patients. Another one for Parkinson's patients that we're just starting to implement here that I really, really like is called Speak Out. It takes some of the same exercises from the LSVT Loud program, but it's a 12-week program. I feel like it's a lot more functional. It has a cognitive aspect of it too. Which is important, I think, because a lot of these patients aren't really just presenting one way. Usually there's voice, speech, swallowing, and cognitive issues, and it kind of touches on all of that. It was developed by the Parkinson's Voice Project, which started in Texas, and they wanted to make it more accessible to their therapists, so they started a certification program. And it's really cool because they'll send workbooks out to all of the patients.
Oh, nice.
So even when we're finished with therapy, they have a clear idea of, what they should be working on at home. So that's one program, I call it a program, one technique that I really, really, really like, and I've seen a lot of benefit with my patients.
Nice. Yeah, I what we're seeing, and we're kind of talking about Parkinson's disease right now, but in just the overall evidence, there is a ton of evidence out there with Parkinson's disease that there's such an importance of not working on one thing, we call it dual tasking, but really working on multiple aspects at one time.
Right.
So for example, I agree with you, in Parkinson's disease, so many times they have their volume of their speech really decreases, and the spouse will say, I just can't understand him or her anymore. It sounds like they're mumbling all the time. But you're right, on that side of it, we also see some of these cognitive deficits. So it's not just maybe the volume of the speech or the articulation, but it's also, you see this problem solving, memory, some of the cognitive problems. So with that, for example, a Parkinson's person. So with this technique that you talked about, how do you get them to talk louder?
So there's definitely an awareness portion of it. So I feel like I don't feel like it's true. Most people I work with Parkinson's have almost like a sensory disorder where they're not able to perceive that they're even talking softly. So a lot of the times I get, well, my spouse has trouble with hearing. That's why they can't hear me. It's them, not me. And so a lot of the training is also awareness training also to kind of teach them, no, this really is an issue. It's not everyone else. But then also...
do you ever record them?
Yes.
Do you? I would think off the top of my head, I would be like, okay, listen to this.
Yeah. So we have a decibel meter too. So we give them a range of this is where you should be in. Put the meter in front of them and have them talk. And as they're looking at it, they're like, wait a minute, that's not where I'm at. Or record their voices. And it's really interesting, the response I get a lot of the times is, that's not me. Or, oh my gosh, you're right, no one can hear me. So, I mean, and it's cool to get to that point because then they're like, okay, the motivation is there and they want to work on it.
Part of neuroplasticity, one of the principles, is that it has to be meaningful to the patient.
Right.
It's something that that person has to want to improve on. So you're absolutely right that speech is huge, because I would think for me, if all of a sudden people couldn't hear me, I would think you would feel less involved
Yeah.
kind of in life, right?
Right.
If it's talking to other people, if it's socializing, if it's talking on the phone. Now we're doing Zoom everything. If it's on a Zoom with your family and they can't hear you, that would be really, really frustrating. So super, super important. I know here, especially with our Parkinson's, that so many of our patients get multiple therapies. So they might have OT, they might have PT, they might have speech. What I think is cool is we all overlap. One of the things with the volume of the speech, I know as a PT, we have them exercising and moving, but at the same time, they have to count or they have to talk to us. And we're always saying to them, we can't hear you.
Yeah.
You need to talk louder. And it's funny because within the clinic, you'll have you'll hear people yelling from one side. So it is just like,
Well, it's funny
so
that
effective.
you say that. When I work with some of my patients, they'll tell me, okay, I think the speech therapy is working because they can hear me in the gym now.
yay! That's awesome.
yeah.
That's awesome. Any other science with any other diagnosis that we work with here or you work with in the neural population?
Yeah, a big population where there's a lot of science behind the treatments is aphasia. And so aphasia is difficulties with receptive and expressive language. So I have some patients who are understanding very well, who aren't able to speak or say much. And then I have other patients who speak well, but there's a comprehension aspect or difficulties with comprehension. In this specific population, the way that they're cued is very important. So I always say that an aphasia brain is very sticky, because if it, for example, starts to do something incorrectly, it kind of sticks. And so we implement a lot of errorless learning with this population. And again, this is where neuroplasticity comes into hand, where we want to make sure we implement the correct way to speak or the correct way to understand, and continue to bombard that in order for the brain to change. So errorless learning is one technique we use with this patient population, as well as many others. So I wouldn't say that there's more of as much of a structured program as like Speak Out for aphasic patients, just because it can present in so many different ways.
Right.
Yeah, so usually we're kind of like picking and choosing different techniques to use with them based on their symptoms.
Okay. Now, I'm going to hold off on my next question until after we talk a little bit about swallowing. Now, at the very beginning of this, you said that your scope is also working on dysphagia, swallowing deficits. A lot of people wouldn't think that a speech and language pathologist would work on that. So let's talk a little bit about that. Can you give me some examples of neurological patients that you have seen that have swallowing problems, and maybe describe a little bit of the variance of the severity of that swallowing problem?
Yeah, so again, it varies, but usually patients notice that they're having trouble with swallowing because they're coughing while they're eating, which is a very, sure sign of it, and people are always bring that one up to me. It's the first one. Okay, well, definitely they're coughing while they're eating, so there must be something wrong. But some other more subtle things that might be signs are like a gurgly voice or a wet vocal quality while they're eating. Some patients show no signs, but you might notice their eyes are watering or their nose is watering while they're eating. And then, of course, choking. Even if it happens one time, that's a sign that something is wrong and you should probably seek an assessment. So those are kind of like the core symptoms that I see, or the coughing, the wet vocal quality, clearing the throat a lot while eating. It could all be signs of something going wrong.
So a question that I want you to clarify is, in my experience, I have had patients where they are the silent aspirator.
Yeah.
So explain what that is and why that's bad.
Okay, so what silent aspiration is basically there is material going into the airway and there's no sign of it. So for somebody like me or Polly, we would cough or clear our throat. Our body would respond reflexively in some way to clear the bolus or whatever is in the airway. But with this population, nothing is triggered, so you don't know that it's happening. And usually we'll know that these people are silent aspirators after they've gotten aspiration pneumonia or sick in some way.
Okay.
Yeah, so there's no way, just based on looking at the person, to tell.
So if you have a swallowing problem, can you eat?
Yeah.
Okay. So how do you help this?
So if you have a swallowing problem, you can eat, but each person's different. So some people have swallowing problems where they cannot eat. So make sure I say that for people who are like, okay,
Here we go.
I'm good to go. So just like if somebody were to hurt part of their body, we would want some sort of imaging to see if something was broken, what muscles aren't working, things like that. So I usually request imaging from a hospital. Sometimes I get patients who come in, they say, I have trouble swallowing and I have nothing to go off of. I'm sorry, I can't help you, I don't know what's going on with you. So I need imaging first, and then based on the imaging, it'll show me if it's a motor problem, if there's weakness, and then there are exercises that the patient can do most of the time, not
So
everything.
what's the imaging? Is it an X-ray?
It's yeah, it's kind of like an X-ray for your swallow. It's called a modified barium swallow test or a video fluoroscopy. It's called different things in different settings.
So they take a picture of you swallowing.
Yeah, it's like a video.
Okay.
A video of you swallowing. And so really good hospitals will send me DVDs so I can watch it myself and see what's happening, but most of the time I just get a report
Okay. Yeah.
that I read and then
Kind of like we do for an X-ray.
Yeah.
Exactly.
Yeah.
Okay.
And so based on that, I kind of pick and choose exercises to do that will make, an efficient, effective treatment program for the patient. We also have Vital Stim. I don't know if you were going to bring that up.
I was, but go for it.
Okay. Vital Stim is an FDA-approved treatment for swallowing. It uses neuromuscular electrical stimulation on your swallow muscles. And the best way that I can describe it, it would be like putting a dumbbell in your hand while you're doing bicep curls. So it just adds like a little oomph to the swallowing exercises you would already be doing without it. There's been a lot of conflicting research in the past about it, so still some facilities are saying, oh, we don't do that. And that makes me mad because there is a lot of good research that it's helpful. And also in my past, I've done swallow therapy without it and can see for myself the results of how much quicker it speeds things along for my patients.
One of the, I do a lot of talks on neuroplasticity, and I use a lot of the time an example of a feeding tube when I'm talking about neuroplasticity, and this is why. There is a principle, use it or lose it. That's one of the principles of neuroplasticity. And I know as a physical therapist, even I teach yoga and fitness stuff, I will say to people, if you stop using it, if it's a muscle, you lose that ability to use it. If it's cognition, if it's using your muscles, if it's doing squats, if it's doing bicep curls, if it's anything. So with the feeding tube, we have worked in brain injury for a very long time, and sometimes when people have a really severe brain injury, first thing they're doing in the hospital in ICU is they're saving their lives, right? So they may be on a ventilator, they may be on all this medication, they may be in a medication-induced coma. So a lot of the times they may put a feeding tube in. And so they're saving their lives, they're doing all this medical stuff, and they're feeding that individual with a feeding tube. And what I have seen, and I want you to elaborate on this, is that I have seen the patient has been on a feeding tube, let's say 6 months. And people kind of ignore or forget to really assess, can they swallow? It's kind of that use it or lose it. They've been using with the feeding tube, they haven't used this, and they're kind of like, oh well, that's okay. But I'm sure I'm wrong. I hope I'm wrong.
It's actually really sad that you brought that up, that that it happens so commonly. But I do have patients that have come that have been on a feeding tube for I'm thinking of one patient who'd been on a feeding tube for a year and had not had any sort of assessment whatsoever if she could swallow. And so during that period of time, when you have nothing going into your mouth, all you're swallowing is your secretions, which are also going to be down because you have nothing in your mouth for a year.
Right.
This all weakens because these are muscles, and like what you said earlier, if you don't use it, you lose it.
Yeah.
And so we have atrophy with the muscles, which is creating a swallowing problem in itself. But then also, it's amazing. I say, okay, well, let's try to eat. And she could eat. And it's just,
wow.
and it's just, I don't know. I think that part of it is, it's such a scary thing.
Yeah.
And so, the family just wants to follow what's been told to them at discharge from the hospital. And, I would probably be the same way. Okay, well, the doctors, everyone says that she can't eat, so she can't eat. But I definitely feel like something needs to change as far as assessing these patients more frequently.
Again, just supports the importance of what you do,
Oh, thanks.
right? I mean, referring a patient to you, and you would look at that because that's under your scope, and just, everybody out there that if you're working in this field, just the importance of even just an assessment from a speech and language pathologist may be able to find something that we could possibly improve. One of the things I talk a lot about in these podcasts, especially in rehab for PT, OT, and speech, is that we have so much evidence of what works. And as a therapist myself, I would love to see patients for as long as I can see them and work them as hard as I can work them until they meet that ultimate goal. Unfortunately, that's not reality.
Right.
Because insurance so much does. It mandates how long we can see patients. And it's frustrating. And, therapists that go in this field to be a therapist have so much compassion. And we want to just help that person and help that person to the very end that they can meet this ultimate goal of talking, being independent again, eating, walking, doing the things that they used to do, but insurance says, sorry, after 3 months, you're off for another 9 months or something like that. So my question to you is, and a lot of the times we talk about this continuum of care, what do you do when the insurance runs out and you're working on something within your scope and you have to discharge the patient? What's the next step, I guess?
Well, one of the first things that I do, it's funny, as soon as I evaluate a patient on the first day, I'm always already planning the goodbye.
Yeah.
So the most important thing to do, if this isn't something that can be fixed within the criteria of the insurance benefits, is implement a good home program. Whether that, if the person needs help, bring in family and teach it to them, but right away. And it should start from the beginning, because in reality, we see patients 3 times a week the most.
Yeah.
And so neuroplasticity isn't going to happen 1 to 2 times a week anyway.
Right.
So the home program is really, really important. Insurance benefits restart at the beginning of the year, so I always tell patients to come in for a reevaluation just to make sure that there's no regression.
Yeah.
So really just make sure a good home program's in place, and then make sure they come back.
Right.
Yeah.
I'm going to give a little plug too, because I know that we've started some virtual wellness classes. And I think your team in speech here does have some virtual wellness classes through the Speak Out program, right?
Yeah, that was another thing I forgot to mention about Speak Out earlier that I like compared to Loud Crowd, or not Loud Crowd, LSVT Loud.
Yeah.
Loud Crowd's what I'm going to talk about.
Yes.
So there's a secondary component to Speak Out to help patients maintain their progress. And so that's what we have going on virtually through the wellness programs. It's a group speech therapy, so I think it's a little bit more fun. It's the same exercises that are done in a individual setting with your speech therapist, but now you have friends thrown into the mix.
Fun.
Yeah. So there's a lot of banter and fun activities that you get to do, plus meeting other people who have Parkinson's.
Yeah, I mean, socialization is huge.
Yeah,
absolutely.
Especially during this time. So.
And we've done some podcasts on COVID. We've done some podcasts on the pandemic, and this just kind of led me into a different question that I've noticed has evolved in the practice here is telehealth. And what I've noticed is that in the realm of speech, telehealth, first of all, is becoming more and more popular, and I think it's super effective.
Oh yeah.
Can you talk a little bit about that? Because I know you're doing a lot of it.
A lot of it. It was actually a really easy transition. I was really nervous about it at first. But it's just like any other speech therapy session, really. With the technology now, I'm able to do screen sharing.
Nice.
So, if I had a worksheet or something I need the patient to read or see, it's very, very easy to show. I've actually, once the clinics reopened, have patients say, nah, I'm good at home. And they want to continue doing the telehealth just because it's so convenient. A lot of my patients aren't driving, so they have to coordinate a ride. So this has been a really, really easy way for people to maintain their attendance.
Nice.
Also, which is helping with outcomes.
Well, I would think too, and I don't think I'm alone. I'm tired of wearing PPE all the time, and I know when we're working with patients, it's masking and it's some sort of a shield, and our patients have to do the same thing. So I would think as a speech therapist, if I was one of your patients, I would be like, well, let's do telehealth because first of all, I can take my mask off.
Yeah.
And that would be beneficial because I know watching the way I talk, the way I move my lips, the way I move my mouth, even if you're working on swallowing, how you swallow is probably a little bit easier for you without...
A little bit easier.
Okay, a lot. Without the mask, I know. So I would think telehealth for speech is like the way to go right now.
Yeah. It's been really helpful for a lot of people. For in-clinic sessions, we do have the face shields, which helps with the facial cueing that we have to do. But still for patients who, they're still wearing their masks. So it helps me too to see what's going on with them.
Yeah.
But yeah, it's been a fun transition. I actually like telehealth a lot. So
yeah, I liked it when I did it as well. I just want to thank you and for sharing all of your knowledge, your expertise, and
thanks for having me.
I'll probably have you back and we'll talk about something else. So
okay.
Thank you. And guys, we will see you next time.
Thank you for listening to today's Evidence to Excellence News in Neuroplasticity and Rehab podcast. We appreciate you and hope that you come back every fourth Tuesday of the month to get more of what's new in evidence and research in the neurorehabilitation world. To learn more about the Recovery Project or to find out what we're up to next, you can visit us anytime at therecoveryproject.net.